I'm Timothy Hallett, Professor of Global Health at Imperial College London.
And I'm Andrew Phillips, Professor of Epidemiology at UCL in London, the Institute for Global Health. Our research is essentially about trying to address the issue of how best to allocate the limited resources that there are in many low-income settings. In particular, our project is focused on Malawi. How best to use the limited health resources that there are to deliver a healthcare system to maximize the health gain for the population from that healthcare system. And in order to do that, that's been done many times, looking at specific disease areas. But in order to do that, we've really had the perspective of wanting to take into account the whole healthcare system and the delivery of everything it has to deliver for all aspects of health. So it's an extremely ambitious project that we haven't completed, but the idea is that hopefully we'll be able to inform the best way to use resources in future to generate most health for populations.
Well, the short answer is that without RSDG, this project wouldn't have been possible. The scale of the problem is really enormous, actually, because we're trying to model a whole population, which varies by age and geography and marital status and underlying risk factors like diet and smoking and so on. Then we're trying to model all of the important diseases that affect that population, infectious diseases, which we have to model transmission among the population, non-communicable diseases, which are affected together and by the underlying risk factors. And then we need to model how all of those healthcare needs are met by a healthcare system. And then we need to have the facility to represent changes in the configuration of the healthcare system and see how that propagates to changes in population health. So it's really an enormous project that requires two things. And this is what RSDG have really made the work possible. One is it requires a very large scale and long running simulation. So the code needs to be efficient, needs to be optimized, and it's being constantly rigorously profiled all the time. And a system has been developed that enables us to seamlessly, in a couple of lines, run huge batches of these simulations on the Azure cloud computing service and get those results brought down to our local machines, which means that the huge complexity of the problem is manageable with those resources. And secondly, there's a sort of code and data management problem, but all of these diseases and risk factors in the healthcare systems all have to interact together. And then there's been, all kinds of other value added from the RSDG, which has been absolutely invaluable. One is the way in which it's enabled our code and our work to be sort of fully documented. Secondly, all of our junior researchers and epidemiologists that have essentially been taught to code in the process of doing this and taught to use modern research techniques like using version control in GitHub. And thirdly, we've been able, I think, to sort of draw on the huge sort of breadth of experience the RSDG team have to bring new ideas, into our modeling. So, because the team have done so many different things in many different areas, like the colleagues we're working with are suggesting often, different ways of doing things, better ways of doing things, new techniques we could use. And so it's actually been a real scientific partnership in that regard as well.